All right. And you're gonna have to remind me the order of um the chapters. Does it have you starting in trauma first or medical? They kind of flip flop.
Medical.
It's medical
What
first.
are we reading?
So this is gonna be patient assessment.
What is it, 14?
Oh, here you go. We'll start with a funny video of that. It still works.
It's fantastic.
So when we talk about EMS, and people ask all the time, what's the difference between EMS and nursing? And one of the easier ways for me to simplify the distinction is, when we're out on the scene or we're in the back of an ambulance, it's just us, right? There's no physician, there's no respiratory team. It is us, our partner, and whatever tools we have at our disposal, which can be really overwhelming. But I think that's a huge reason that people are drawn to EMS is the autonomy and the freedom and the responsibility that comes with it just being you, right? So sometimes what's the most liberating thing about the job we love is also the most terrifying thing of the job we love. So it comes down to how do we organize information? How do we organize data to proceed in the smartest way that's best for our patients so that we don't miss something, and we render the best care that we possibly can. When you look at kind of what I'm going to call the older school days of the National Registry, they had these skill sheets, and they still have them. You're going to get used to them, but they used to have a lot more, right? And that skill sheet was spelled out step 1, 2, 3, 4, 5, 6, all the way through the end. And there was some good and some bad that came with that. Part of it was, people, the negative side of it would say it's really robotic. It doesn't really work that way, right? Everyone always complained that vitals would occur at like step 20, when really in real life we're doing vitals up to like step 3. As I said, it's not really practical to real life. It doesn't tend to play out that linear. Okay, but then there's there's the other side of the coin that says we need to train that way. That we need to train step 1, 2, 3, 4, 5, 6. Why? What would be a reason why that's a good way of training?
When you get nervous, you get panicked, you can default to your trainings.
Yes, exactly. When we go into a fight or flight situation and our adrenaline's kicking, our heart's racing, our blood pressure's up, we tend to forget about what is typically in the front of our conscious brain. We could test this right now by going outside, running laps around the station for 5 minutes, jogging up the stairs, hopping down on the floor, and doing CPR. All of a sudden, that conscious ability to count to 30 compressions, 2 breaths, and to carry on a conversation with me, it would be compromised because we have activated your fight or flight system. It is much harder to be consciously aware when we're in that type of state, whether it's exercise, stress, anxiety, whatever it is. It's very hard to focus in that moment. So when we hold ourselves into this type of training standard, when it's always A, B, C, D, or 1, 2, 3, 4, we can be in that fight or flight and still be successful in what we're doing because we've been so programmed to respond this way. When I taught in Minnesota, there was always this running joke that each new semester there'd be a student who would come forward and say, I had a weird dream about my skill sheet last night, right? Because that's how much we're thinking about. It used to be like 15, 20 pages of skill sheets, and I'd hand them out on night 1 of class, and I'd say, by the end of class, you're going to have these memorized, not individually, but together. You're going to have all 20 consecutive pages memorized forward and backwards, because that's the mentality we need to have with our skills. It really does work. But when we train that way, like we had talked about before, we have to remind ourselves that healthcare doesn't work that way, right? So there's a bright side to being that black and white, and then there's the unrealistic side of it never really plays out that way. So we have to understand the value in it without becoming completely encapsulated by the fact that it doesn't play out that way ever. So the first thing we do in our patient skills or patient assessments is we break it up into 5 parts, right? We talk about, if you have a really messy apartment or a really messy house, we don't wake up and go, okay, I'm going to tackle this messy house today. How do we typically solve that problem? We're going to break it up into rooms, right? I'm going to start in the living room, then the kitchen, then right? We break our problems up into smaller problems and then divide and conquer. That's really how we look at every assessment we walk into. So what I want you to really focus on after we go through this lecture is every time you go out on a call, watch your paramedic or your EMT and see, are they physically doing these parts, right? And it might just be mental clicks in their head. So it might be a little less obvious, but are they breaking it up into these segments? And it might be a little bit out of order because the longer you do this, the more you kind of develop your own routine and your own style. But we should be hitting all of these pieces, right? So we start with scene survey. What do you think the focus is within a scene survey? So this is that moment between the tones go off, you get in the truck, and you get to your scene. That's that chunk of it. What things do you think we're focusing on or thinking about?
Safety.
Safety is number 1, right? Is it safe for us to be there? What else?
What you need to be prepared for.
Okay, what we need to prepare for. What else might come into our brain?
Research.
Yeah, what kind of resources do we need? Okay, we just went to a motor vehicle accident last night involving 3 patients. Do I need more ambulances? Do I need lighting so I can see where my patients even are? Do I need extrication? Do I need a helicopter? Do I need PD? Okay, good. Primary assessments is obviously the primary focus of patient care, trying to learn as much information as we can. History taking, learning their background and where they come from, what ailments they have that will contribute to the acute issue. What does acute mean?
Current problem.
Right here, right now, right? Versus what's the opposite of acute?
Chronic.
Chronic, good, over time. Secondary assessments, okay. This is probably a big one that providers tend to struggle with because we'll talk about tunnel vision and how easy it is to get sucked into what is the glaring problem. We can forget to do that secondary assessment that either A is going to give us more information to support our treatment, or B, some new information telling us we also need to be focusing on something over here. Case in point, when we do trauma calls, significant trauma calls like our MVA yesterday, we make them trauma naked. Why do we do that? We don't do it because we like to do it. It's a bit awkward for everybody, but why is it really important that we cut their clothing?
You do the whole picture.
We need to see everything, right? So if we bring someone in from a car accident, we don't fully expose them, right? And they're complaining of they're having some chest pain from where that seatbelt pulled on them. And we roll into the ER and we go, yeah, she's having some chest pain from the seatbelt. And they cut his pant leg up and see his femur sticking out of his thigh. That's a big problem, right? Did we treat the most glaring issue? No. An exposed femur fracture is life-threatening. And they truly might not feel it in the moment because they're in such a state of shock. So those secondary assessments, whether they're head-to-toe assessments or focused secondary assessments, we'll talk about the difference, are really important to ensure that we, A, caught everything there is to catch, and that we're working down the right path and supporting our treatment and care. And then reassessment. I think we naturally do this, whether we're aware of it or not. How do we know if our treatment is working if we're not reassessing, right? So how do I know if I give someone a pain med that it's actually helping them? I don't ask them again, how is your pain doing a few minutes after I give it? So scene size, so again, get into the mentality of this happens the moment your tones go off. This does not happen when you arrive on scene. This happens as you're going to scene and during your arrival. Then the first question we want to ask ourselves, are we getting all the information we need? The most common example is, please respond out to Highway 281 for a 2 vehicle accident. Is there any additional information you'd like to know with that?
Many patients.
Yeah. How many patients? How do I know what resources to send if I don't know how many people are involved? What if they don't know? What if they say we're not sure how many patients?
You go figure it
That's 15 miles out of town on 281.
out. These for extra just in case.
Maybe, but now you send 4 and there's only 1 patient. What would be another way we could approach this?
Ask what kind of vehicle they drive.
Yeah, what kind of vehicles are involved? Okay. One is a SUV, say it's a Ford Expedition. The other one is a 4-door car.
So up to 11 people.
Okay, so we're gonna assume they're full, right? Good. Okay, mechanism of injury, right? In the case of an MVA, was there an ejection? Was there airbag deployment? Did it roll? How significant is the intrusion on the vehicle? Was it head to head? Okay, all those types of things. Now, obviously, our dispatchers have a job to do themselves, and if they're trained in emergency medical dispatch, they're trained to ask these questions. But they have a lot going on. There's a lot of things to try to sort out in their position. So we might have to clarify some of that and ask those additional questions, while also trying to be mindful that they're probably getting multiple 911 calls, especially in the case of an MBA that they're trying to sort out. On the way there, we should be thinking about BSIs. In today's world, it's probably better known as PPE. What is that?
Personal protection.
Okay, or basic standard isolation. Okay. What do I need to protect myself? So let's stay on the car accident track here. What types of things should we be thinking about there and keep us safe and protected?
Gloves.
Gloves?
Your high vision.
What kind of gloves? Latex gloves for blood. What, any other gloves?
Depending on how cold this, how long you're gonna be able to see.
Yeah, we just extricated someone out of a ditch yesterday and my latex gloves were freezing to the handles. So do I need winter gloves? Do I need leather gloves? Am I going into a vehicle? I need to protect myself from glass shards and things like that. Okay. You'd mentioned high-vis vests. Are those optional on these calls? No, it's a law actually. You have to wear a high-vis vest or your high-vis jacket. Okay, what else? Eye protection is huge. That's probably one we don't focus on enough in our field.
Do glasses count? Like you would like wear glasses?
OSHA says the definition of eye protection has to have side blinders, or not blinders, but the side pieces to them, but this is better.
Turn stuff.
Okay, yeah, again, if you're going into a car, which does happen, we would absolutely send you through a back window if we come get to somebody. I'm not going, so there's where being the small one, you get to crawl into all the fun places. You're going to be in there a while, and we're going to be handing you tools. So do you have what you need to keep yourself warm, to keep your patient safe? When the fire department starts cutting that car apart on top of you and all that stuff starts to fall, and some of it's just hot shards of metal, right? Do we have everything we need? Helmet, hard hat, that kind of stuff. And then again, I go back to getting into the resource part of it. Like, do I need lighting? Do I need extrication? Do I need the jaws of life to cut this car apart? Those types of safety things as well. I actually have a video request in to pull the footage from our MBA yesterday, because I'll tell you, whether it's highway, interstate, people do not care that you are pulled over with your emergency lights on. They are blowing past you. We were down in the ditch and I could feel the wind coming from those trucks because they were not slowing down. So that's something to be mindful of too. Our fire department does an awesome job of positioning their trucks in areas where they're going to shield us if someone were to come flying into us. So all scene safety, protective things that we need to be thinking about. And then how do we determine whether or not a scene is safe? This is a really tough one. What would be things that we'd be thinking about?
No, I'm sorry, electrical wires.
Okay, are there any environmental or condition hazards that would make it not safe for me to be there? A down live wire, or whether or not we even know it's a live wire, right? There's a chance it is. That's a problem. Okay. What else?
say it was like a truck, what kind of material they're carrying.
Yeah, are we in a hazmat situation? Do we need to back up? Establish a perimeter here? Okay, what else? More often than not, walking into a scene and mentally asking yourself, is it safe for me to be here, is enough for your instinct to tell you whether or not it is. Right, now there's some habits that we try to build early on in our providers to always keep us safe. And those are things like, for example, when we knock on a door, we knock from the side, right? Not from directly behind it. You guys cover that part yet? Okay, so that's a scene safety thing. If I'm going up to this door, I don't knock like this. Why not? I have no idea what's on the other side of that door, right? There are some people out there, they don't like first responders, right? And typically we think that aggression is more geared towards police officers, but they don't care, right? So we don't know what's on the other side of that door, but they certainly know what's on this side, right? So when I knock, I'm over here, okay? In fact, I just had that. I went to a call a few weeks ago and the house that looks pretty abandoned to me. All the windows were broken out. It was very dark in there. Didn't look like anyone was living in there. And for the first time in a long time, my spidey senses went up on that. Like, there's something wrong with this. So again, I messed up because I moved to the side and knocked before Taylor was standing right here. And I didn't be like, hey, you should also move. I just, hey. But yeah, open the door. There's no furniture in this house. It's completely dark. It had bad intentions written all over it. You know, so it's those little muscle memory things that we really actively have to think about early in our career, so that we develop a habit 5-10 years in our career. Going, yep, nope, something's not right. What other scene safety things? It's not always about someone trying to hurt us.
Yeah.
Animals. Yeah, there was a provider the other day said that some of the crews were picking on her because there was a small little ankle biter dog. I don't care. Hey, that's a horrible thing to be picking on someone about. A dog with teeth that you don't know is a danger to you. Okay, and I love dogs. I'm one of the biggest dog people you'll ever meet. But you're there putting hands on their owner. You have no idea how they're going to react to that, and they could bite you if they don't have their vaccines. You could be in for some issues, right? So that's not something we joke about or belittle about. We can, kind of razz each other for it later, but in the here of the moment, we have to understand, even though it's that cute, adorable looking poodle, it's a danger to us because we don't know it and it does not know us. Okay. What else?
Weapons or on like drug calls, sharps.
Sharps, yep. So when we do EMT labs, we run what's called moulage scenarios. It's like live simulation training. And one of the first things that we're testing early on for our EMT students is their ability to read a scene. They're not far enough along in the program yet to really have a good understanding of patient care and patient assessment, but they should know how to read a scene. And one of the things we do is we place objects around that scene that could hurt them, and we overwhelm their senses, just like I was talking about before. The goal is to kick them into fight or flight and to see what they're still cognitively aware of their surroundings, so that we can regroup afterwards and say, did you see that wire hanging over there? Did you see the knife sitting on the counter? Did you have your entrance and exit planned to see, are they still kind of maintaining control of their conscious mind, even though their hearts and their respiratory rates are through the roof? How about weather? Could weather conditions make something not safe? What would be an example? Lightning and thunder could be a problem. Prolonged exposure to that. How about cold? Yeah, we're not going to do anyone any good if we have hypothermia and we can't feel our fingers, right? So obviously some of that stuff we can try to mitigate, but prolonged exposure puts us at risk and we don't want that. Okay. How about illness? Can illness present scene safety issues? Okay, COVID probably taught us that the most. Influenza right now is teaching us that a lot, of knowing, do I need to put a mask on to protect myself, or even better yet, and especially in your case, working at a nursing home, do I need to put a mask on to protect the people around me, right? I think about that all the time. It's like, what kind of things am I bringing home to my family? So for that case, maybe I do need to wear a mask around this patient who's got coughing symptoms and a fever, and so that I don't bring that home. Some of the stuff that we talk about, scene safety, knowing you're in and you're out. Yeah, there's another area of conscious focus. It's not something we think about unless we force ourselves to think about it. Your entrance into a house may not always be your exit. Right? So are we consciously aware of that? If things go south right now, and we all have that instinct, right? When there's that patient who's acting just a little off, right? We tend to get our guard up a little bit. That's the moment we got to know. Okay, if things were to go bad right now, how am I getting on? Again, I go back to the abandoned house. There was a person inside of it, and they did get very aggravated with me and my partner. And this individual placed herself in between us and the door, and that was our only entrance and exit unless we were jumping out the living room window. That was a bad deal. That was get on the radio, get PD, order them to get out of the way and get out of the house. And it happened like that. Okay, it takes very little for things to trigger to start heading in a bad direction. So know you're in, know you're out, and identify any life threats to you and your crew. When we look at safety, there's a cultural fix that we need to make sure we're keeping tabs on. When you watch the movies and TV, or even there's some healthcare providers who act this way, they go, I would gladly risk my life for my patient or whatever. No. I mean, that might be true, but that's not how we go about this. If you're willing to put your own safety in jeopardy for someone else and something happens to you, say you die, how many other patients are you not going to be here to take care of because you put yourself in that spot? Right. So we need to think long term. Nothing's worth dying for. So when we look at our priorities, our safety priorities, you are always number one. My safety comes before anyone else's. And there's going to be moments in our career where we have to jeopardize that a little bit, but your safety is your number one priority. Your second priority is your not your patient, your partner. Okay. Your job is to make sure your partner goes home. Their job is to make sure you go home. And then it's your patient. So you get put in that situation, you got to pick and choose. It's you, your partner, your patient. Okay. Next thing we need to do is determine our MOI or the NOI. MOI is mechanism of injury. NOI is nature of illness. So when we go to an 911, we're going down two different paths, right? And sometimes they intermix. It can happen. We'll go through some examples. But we're either there for trauma or medical, right? And if it's trauma, it's mechanism of injury. What has caused the trauma, right? Was it a car accident? Was it a slip and a fall? Was it an assault? Okay. What is the mechanism? What happened? And if it's medical, it's nature of illness. What has caused the illness or the symptoms? Okay, so that's where our paths are going to split a little bit here. We have to determine how many patients there are. That's huge, right? Again, something if we're not thinking about it, it can really come back to bite us. When I worked in Minnesota, we got called out for a bus accident. It was one of the smaller yellow buses. I don't know what their full capacity is, but I'm guessing it's probably about 20 to 30 kids. Got hit by a semi, and there was some known ejections. We know school buses don't have seatbelts, right? And we thought we knew the head count of every student on that bus. We had 3 different helicopter entities land on scene. I'm guessing we had 5 or 6 ambulances. But it was very rural, so we're sending all of these people to different places. And I was the last truck because I was in charge of the scene, so I was bringing our most stable patient to a small rural hospital. And as I was leaving, some gentleman started waving me down, saying, "There's another one down here." And he points, and there was a kid laying way off scene. I don't know if he was thrown this far, if he wandered off this far before people showed up, but he was way down in the ditch by a stop sign. We almost missed that kid. So having that head count and then not trusting the head count. So when you get those firefighters and police officers and bystanders putting teams together, go sweep the ditches, go do everything, and make sure that we've accounted for every person that's here. Which again leads me to additional resources. What do we need? And this is where we kind of get into like mass casualty territory sometimes, but we can get tunnel vision or maybe narrow vision on this question a little bit because we tend to think of resources being fire, PD, right? It can be far beyond that. It can be lighting. It can be, hey, we're going to be at this chemical train derailment for the next 3 days. Can we get some porta potties out here, right? It's whatever resources I need to help me succeed and do this job. And then the next question is, do we need to consider C-spine and mobilization? And I would imagine you probably have not gone over C-spine and trauma yet, or you have a little bit. So when I started in EMS, anyone who had a significant mechanism of injury or was complaining of any type of head, neck, or back pain, they were getting put in a C-collar and being put on a back. And today, research is showing us that the backboard rarely ever helps. It can actually make things worse. So not nearly as many people get backboarded nowadays, but the C-collar is still really important to us. And we will put that on just based on mechanism alone. But there are some criteria that we follow that really help us decide yes to a C-collar or even to a backboard. And that criteria is called Nexus. It was developed by a group of physicians in Canada that has over a 90% success rate. And basically, there's rules that factor people in and factor people out on whether or not they need a C-collar or they need a backbone. The big ones are if they're complaining of midline cervical pain, so in the center, they're getting a C-collar. Okay. Any limited range of motion, they're going to get a C-collar. If they're complaining like, yeah, no, my pain is like out towards the outer edge of my neck, the lateral edge of my neck, and that's their only complaint, they don't need a collar. And that's muscle area, not or vertebrae. And then there's some rule-in factors as well. So if they are intoxicated, they're getting everything, right? Because their senses might be dulled down enough where they don't really know. If they're altered level of consciousness, which kind of ties into intoxication, or if they have a distracting injury, meaning if their leg, the bone in their leg is sticking out, and you ask them, are you having neck pain? They go, no, it's my leg, right? They could be having neck pain if they're distracted by the fact that their bone is sticking out of their leg. I believe ejection is it's a rule-in factor. You're ejected from any type of vehicle. But make sure you remember the word nexus. It's something you're going to want to refer to Nexus. And in fact, when I document whether or not I backboarded or immobilized someone, I write the rules of Nexus in my report. I will say, due to positive known intoxication, patient was backboarded in reference to Nexus criteria. Have you guys gotten to play with the C-collars a bit?
Another question.
Yeah.
I had the nursing home master.
We'll do homework with these a little bit. So. Knowing how to, knowing how to properly size these and how to properly put them on is really important. Because you can't manipulate their head in order to get it on. It kind of defeats the purpose. So we'll work on that. All right, then we move into the primary assessment. So we've got all that scene survey information. Now we're going to move into that primary assessment. This starts at the moment of us walking up to our patient. It's before we start talking to them, but we now have eyeballs on them. Okay. I say that because the first two bullet points are as you are watching and approaching. Okay, so from a distance, can I see anything that's a life threat? Any major arterial bleeding, any respiratory distress, and anything that will compromise airway, breathing, or circulation. Okay, and then what is my general impression? One of the sub points to that, I don't know if the textbook still says it, but they would say you should ask yourselves, are they sick or not sick? And it's kind of that like instinctual question. Same thing as, is it safe for me to be here? Like our gut will just know, yeah, no, they don't look very good, or no, they seem okay. Doesn't mean that they don't need an ambulance, but no, I think they're stable, right? That gut reaction, that gut feeling tends to be pretty accurate. Okay. When you do your skill sheets, it's going to ask you to verbalize your general impression. One thing that drives me crazy is when a student looks at their examiner, the person running the scenario, and they go, okay, and what do I see? like, make some efforts. I know it's simulation, we can't always replicate everything. But you should verbalize out and say, okay, I see a female sitting upright in her chair. She's tracking me with her eyes. She doesn't appear to be in any respiratory stress. And then you can ask your examiner at the end, is there anything I should know that I'm not seeing, right? Because there could be something more there. It's just simulation that we could not portray it. Okay.
At the end of the full simulation or just at the end of your job?
No, you're during your simulation, you're having this active back and forth conversation with your exam and with your patient. Okay. And then we're going to determine that chief complaint. So now we are interacting with our patient. So what is that chief complaint?
When they call.
Okay. And so the question we always ask is, let's say you walk up and their arm is very clearly broken. The radius is broken, it's open, it's bleeding. And you say, okay, and what seems to be the problem? Why'd you call 911 today? And they say, I have a headache. What's their chief complaint? So their chief complaint is always going to be what they say it is, not what you think it is. Okay, the only time that there's a distinction is if they're unconscious. Okay, if you walk up and say, what seems to be the problem? They don't respond to you. What is their chief complaint?
Unresponsive.
Okay, good. After we've determined the chief complaint, we need to establish our level of consciousness. There's a couple different ways we do that. First, we need to know, are they alert orientated? There's a difference between being alert and being orientated. Okay, if you walk into a room, excuse me, if you walk into a room and I turn my head and I meet you guys with my eyes, I'm alert. I know you're here, right? But then you say, hey, can you tell me what day of the week it is? And I say chocolate pudding, right? I'm not orientated. Okay, so you can be alert. It does not mean you're orientated. How do we determine if someone's orientated?
By, person, place, time of it.
Good. Person, place, time. We can also test their long-term memory versus their short-term. Okay. And then AVPU stands for alert, verbal, painful, unresponsive. You can have different levels of alertness, right? So they're alert and orientated. I talk to you, you talk to me, you're alert. Okay. If I talk to you, you don't respond to me, and I do a sternal rub on you, and you flinch or you withdraw, you are painfully aware, right? You're painfully alert. Okay. Oh, I skipped one. So alert, the A in alert would be you respond in a way that makes sense, right? Like, what's your favorite color? And you say blue. Yep, you're alert. You know what's going on. Okay. If I say what's your favorite color and you say banana, right, you're verbally responsive. You knew that you needed to give me a verbal response, it just didn't make any sense, right? And then the painful response. I do a sternal rub, you respond to it, you're painfully alert or aware. And then you is unresponsive. So sternal rub or whatever you do for pain, and they don't respond to that, then they're unresponsive. Okay. Any questions about that? No. Once we've determined their level of consciousness and their primary complaints, then we need to get into ABCs. Now, this is where we can get ourselves into a little bit of trouble. It's really easy to walk up to someone and see their leg, their bone in their leg sticking out and just get driven right to it, right? But that's not going to kill somebody. What is going to kill someone is someone who has compromised airway, breathing, and circulation. So that always has to be our priority. Okay, so assessing A, B, and C. First thing we're going to do is treat immediate life threats. Okay, is there anything that is compromising our airway, our ability to breathe, or our circulation? Okay, we're going to look at RRQ, stands for rate, rhythm, quality. Okay, we want to know that about their pulse and about their breathing. Is the rate fast, slow? Is it regular? Is it irregular? Is it strong? Is it weak? Same with breathing. Are they breathing fast, breathing slow? Is it regular breathing, irregular breathing? Is it equal chest rise and fall? Okay. Keeping tabs on those. Again, obviously for pulses, you got to actually palpate the pulse, but that those respirations and ventilations, we should be able to see that in the walk up. Okay. So the first thing we're going to rule out, it is always the priority of A, B, C. Airway always takes priority over breathing. Breathing always priority over circulation, except for one situation. There's one situation where it rearranges to cardiac airway breathing. What situation would that be? Nope. Fine, you're not entirely wrong, but that would be a life threat, right? So that life threat is being addressed before you cease, right? If we're talking arterial. If it's a venous bleed or something, you're gonna be okay. What scenario would cardiac come before airway breathing? Exactly. CPR, compressions, right? So cardiac turns to compression airway breathing because we're going to take over the cardiac function. The easiest way to think of this is if my patient calls me because they're having chest pain, it would be fair to say your priority should be cardiac, right? Circulation. But you'd be wrong because if you show up and yes, they're having 10 out of 10 crushing chest pain, but their airway is compromised or not secured at all, that unsecured airway will kill them far faster than the circulation problem, right? Because if I don't have a good airway bringing what into my body, oxygen, does it matter whether or not my circulation is working? Not really. Great, you're moving blood, but you're moving unoxygenated blood because you're not delivering, okay? That's a problem. So airway has to take priority. If you move down to breathing, again, the circulatory system is moving blood, that's fantastic, but you're not breathing. So does it matter that the circulation is moving? No, because what does it still not have? Oxygen, right? If we're not ventilating, we are not allowing the process of what to happen. So to the D. Diffusion. If diffusion is not happening, then what's the point, right? Now, again, that odd scenario of CPR, we need cardiac or circulation first because if there's no blood moving, then what's the point of A and B, right? So that's the only one where it gets a little different. But airway, breathing, and circulation in that order is 99% of our patients. So the first thing we do when we look at airway, we go, is their airway open, clear, and protected? What's one quick way we can tell immediately if someone has an open and clear airway? If they're talking, right? If they're talking coherently, right? If we're having a back and forth conversation and I'm making sense to you, you know that I have pretty good control over my airway. If you're talking to me and I'm mumbling because I'm blackout drunk, I might be protected for the moment, but you need to keep a very close eye on it, right? Good. If it's not open and clear, we got to look at some different methods here. We have two different airway adjuncts that we can use to help keep someone's airway open if they can't do it themselves. The first one's called an OPA. It stands for oral pharyngeal airway. Okay. It is a like a plastic tube, and we'll play with this too. That essentially goes down their mouth and keeps their tongue drawn down. Okay. When we go unconscious and we lose control of our airway, it's usually our tongue that likes to fall backwards because that muscle underneath it goes flaccid. That tongue falls backwards, it sits over the top of our epiglottis, and now we're not able to get air down because we're just sucking the tongue down into our airway. Okay. So that OPA is going to come in, it's going to sit curved, it's going to keep that tongue depressed. One thing we got to be really clear about with OPAs and MPAs, this is not a oxygen delivery device. You're not intubating them. This is not any type of intervention that has anything to do with their ability to ventilate, other than keeping that but keeping that object out of the way. Okay. And MPA stands for nasal pharyngeal airway. Hopefully that's making sense so far. Oral pharyngeal airway goes down what? The mouth, the oral cavity. The nasal pharyngeal airway goes down what? The nose. Okay, so these are rubber tubes that slide down the nose. They come down the back of the mouth and they sit right here to, again, keep the tongue and other objects out of the way so that when we breathe with a BBM, that air is not going to be restricted. Okay. There's some rules we need to follow with OPAs and MPAs. Obviously, what would be a situation where you could not use an OPA?
Gag reflex.
Yeah, they have a gag reflex. That's not going to work very well. Okay, a really good way to test whether or not someone has a gag reflex, and it's not 100%, but it's a good indicator. Sometimes you just got to try it and see what happens. Is when they're unresponsive or unconscious, take your finger and start rubbing their eyelash. You get that eye twitch. there's a good chance they have an intact agent. Okay, and again, it's not a perfect way. It's always going to be a risk or a gamble if you're going to place an OPA, but it's a good thing to try really quick to see if they can tolerate it. Okay, the OPA, you pretty much have to be unresponsive, and the OPA can be flexed. Okay, NPA, you can do this to someone who is alert and conscious. Okay, someone again really intoxicated, we might use an NPA on to keep their airway open if they were to quickly go unresponsive. The contraindication to it would be severe head trauma. Okay, so there's a hole in the back of our nasal cavity that leads into where our brain sits, and so if we're worried about any level of brain swelling, that brain can swell and compress up against that hole, and we don't want that NPA inadvertently poking at it. It is incredibly uncommon, incredibly rare, but it is something that we need to be taking into consideration. Could you use both? Would you put both of these up? Yeah. very unreliable in kids, also really unreliable in geriatrics, and unreliable for anyone with full climate. So this one doesn't help us a lot, hence why you don't see us do it a lot. But the idea behind cap refill, right, to squeeze on the fingernail bed until it's completely white, let go, and it should take less than 2 seconds for the color to come back, okay? If it's delayed, that tells us there's an issue with circulation, which is why it doesn't work on older people, because they already have compromised circulation, okay? Once we have those ABCs kind of figured out, then we gotta make our transport decision. You're always gonna hear people use the phrase, is this a load and go or a stay and play? When in doubt, the answer is always what? Load and go, right? You'll hear us talk to patients all the time and say, we can't see inside of you, right? So even though I can do a 12 lead and tell you you're not actively having a heart attack, that doesn't mean you're okay, right? Or if someone says my hip really hurts, I go, it doesn't look deformed, doesn't mean you're okay, right? There are things and tests that need to be done that are beyond our capability. So they could very well be a load and go, even though they look pretty good, they look stable, right? So when in doubt, everyone's a load and go, we're gonna move, right?